Hello, my name is Fernando Alfonso. I'm an associated editor from JACC Interventions, and I have the pleasure to be here with Adel Aminian from Belgium that presented a very interesting late-breaking clinical trial today here in Paris, yesterday in Paris, and it's something about RADIAL, the different approaches to get access. So tell us what it's all about.
So yesterday we presented the result of the large multi-center DISCO RADIAL. So it is the largest multi-center randomized trial comparing conventional transradial access with distal radial access. The particularity of this trial that it's a fair comparison between distal radial access and conventional radial access with systematic implementation of best prevention practice against radial artery occlusion. The primary endpoint of this trial was the occurrence of forearm radial artery occlusion at discharge, and also we have taken the opportunity from this large multi-center trial to assess also case secondary endpoints like crossover rates, because it's a more demanding technique, distal radial access, also the hemostasis time, and also some vascular access site complications. So this is one of the largest study published to date. And it's a very important trial because there are two recent papers in JACC Interventions showing that when you use the distal radial access, actually you can end up with a very low rate of forearm radial artery occlusion, and you keep like that the forearm radial artery patent for future procedures, which is something that is very important because transradial access is now the recommended access, and many patients will have to come back during their lifetime for further procedures, so it's very important to keep it patent. So, the result of our trial showed that we have no difference, actually, in the rate of forearm radial artery occlusion, and both groups ended up with a very low rate, which actually is a promotion of best prevention practices against radial artery occlusion. So, these results are slightly in contrast with what has been published before, but the rate of occlusion in the conventional arm, has decreased really very much as compared to previous trials, so because of those best prevention practices.
Okay, so I think we already published a couple of those randomized trials in JACC, and there are also some studies, but this is the best, the first large study assessing this in an international multi-center trial, and using this profile strategy to promote optimal hemostasis. Can you explain a little bit the reverse barcode sign and all that we use in this study?
First of all, I would like to say that the distal radial access by itself, if you consider as a single method to prevent radial artery occlusion, is very efficient, and we proved that again in this trial because the rate is extremely low. But the novelty is that on the conventional arm, using best prevention practices, what you say, the PROPHET trial, the patent hemostasis. So we have published in JACC Intervention 3 years ago a consensus document on what are the best prevention practices to prevent radial artery occlusion. And these are numerous. That include adequate procedural anticoagulation, keeping flow in the radial artery during hemostasis. So it's the so-called patent hemostasis. And you can also achieve that if you have a minimal pressure strategy with a short hemostasis time. So these are very simple recommendations that can really lower the rate of forearm radial artery occlusion. That was implemented in the trial, in the control group, which was conventional radial access. And we ended up with one of the lowest rates reported in the literature. So actually we set a new benchmark. So we see that many trials assessing radial artery occlusion are having rate of occlusion above 5, sometimes up to 10%. This I think is not acceptable in current practice, because having an occlusion 1 every 10 patients, I think it's not possible. So I think the people that will continue radial access now have some food to say that okay, they have to continue best practices to prevent radial artery occlusion. On the other hand, people doing distal radial knows that this is a good access, relatively safe, and also associated with low rate of occlusion.
So let me ask you about the technicalities, the technical details. So you use a special introducer. Do you ask people to have a large studies, like I understand 100 procedures, and you use ultrasound sometimes to do the distal radial access. And of course, for the primary end, you check radial artery occlusion by ultrasound, because ultrasound at discharge. Is that correct? So explain a little bit the technicalities.
So the distal radial artery is smaller than the forearm radial artery, and it has also a less predictable course because it's curvilinear. So the puncture is more demanding. So some operators in the study, I know they have used ultrasound to access the artery, especially at the beginning of their experience. And after a certain amount of cases, they just do it by.
So you don't think this is required, right?
I think I don't have any data to show that it's. I think like always, ultrasound access is always safer. So I think for the beginners, it could be a good option. But also knowing the anatomy of the distal radial access, where to puncture into the anatomical snuff box, how to place the hand of the patient to see your anatomical landmarks. These are all technical aspects that are very important. Regarding the sheet size, we have used what we call a slender sheet. So it's a dedicated radial sheet with a reduced outer diameter. I think this is very important when you do distal radial access because the size of the distal radial is 1 French smaller than the conventional radial. So it's very important to use a slender sheet when you do distal radial.
So to summarize, your primary endpoint wasn't met because the occlusion rate was very, very low in the body,
Both groups.
but it was 3 times lower in the distal radial access, and the price you pay for that is to double the rate of spasm and also the rate of occlusion.
Exactly.
So what will be your take-home message from that? Would you recommend doing that to people like myself without experience to that, or just focus in best practice to achieve optimal endostasy? Where should we go?
That's a golden question. I mean, I think it's a trade-off between a more demanding puncture for the operator with the absolute difference in crossover was 3%. So it's not so large that we would think. And once you get the access, the procedure itself goes very well. And at the end of the procedure, the hemostasis is easier. So it's a trade-off between a more demanding puncture, and at the end you benefit from easier hemostasis. I think that people have to see in their own practice how they can. If you want to get the benefit from distal radial access, you have to start your program. You have to start your program, and you will end up, I think, with some benefits. For example, the position of the hand for the patient is more comfortable, also for the operator. The hemostasis is really easier. It's one of the main benefits from distal radial access, the hemostasis. And also in centers that don't have the time to take care of the hemostasis, I mean, you will end up with a low rate of occlusion, keeping the wrist access for infusion. And if you have a crossover in the study, it was mainly on the ipsilateral radial access. So you keep up with the wrist access and all the benefits of the wrist access. Yeah.
So that, as far as I understand, we need to pay major attention to hemostasis. That sometimes we forgot, and the nurses and everybody's this in the cath lab, we don't take care of that because we understand that the hemostasis time was also short. So this is very important.
Exactly.
Now, my question for all these people, pushing for this distal radial artery approach, where are we going? I mean, what will be the next trial you will decide to push for this new access?
So it's a very, very important question that you're asking. I think we have shown that rate of occlusion is low, so we don't need another trial showing that rate of occlusion is low with distal radial. I think now we have to focus on the technical aspects, how to increase the success rate, and also we have now to show how we can achieve even shorter hemostasis. So there's a lot of studies that we can do, but more focusing on the technical aspect and not anymore on the rate of forearm radial artery occlusion, which actually is low in all studies. So I mean, that's my main message.
So thank you very much and congratulations. It's a pleasure to having you here in Paris and having your paper in JACC intervention.
Thank you very much.